Good afternoon. My name is Nicolas Doll. I'm a cardiac surgeon from Germany. I am located in Bad Rutenfelde in the Schuechtermann-Klinik. No one knows this name, but it's a very large, integrated and interdisciplinary heart center with a focus on the treatment of atrial fibrillation. It's a great pleasure and honor for me to present on the EHRA Congress this year our one-year result from the CSAF trial. It all began almost 10 years ago when a friend of mine and I were thinking about how EPs and surgeons can collaborate to treat patients with advanced atrial fibrillation. That means patients, challenging patients with long-standing persistent or persistent atrial fibrillation, because till today we know that we are not that good in treating these patients on our own. The hybrid ablation for the treatment of atrial fibrillation consists of an epi and endocardial ablation. So that has nothing to do with the battery on a wheel. And we need to work together, electrophysiologists and cardiologists, in a two-stage procedure. That is the meaning of hybrid. We treat patients with long-standing persistent and persistent atrial fibrillation with the hybrid procedure. There are some studies who could show that these patients are very challenging, and due to 3D complex mappings, we have seen that there is an endo and epicardial dissociation, and that is the reason why we go for hybrid ablation. The inclusion criteria for these patient cohort is patients who suffer from persistent and long-standing persistent atrial fibrillation, and patients who have enlarged left atria with bigger than 4 centimeters. The exclusion criteria were patients who had previous catheter ablations. That means we were looking for de novo patients who never had treatments before. So we compared the hybrid ablation in a 2-to-1 randomized fashion to multiple catheter ablation. And we found out after 1 year, through 12 months, absolute benefit of 32% in favor of the hybrid procedure. Okay. Yes, we have seen differences in subgroups, but I have to mention that subgroup analyses were not powered for this study. We compared persistent and long-standing persistent patients. We have seen the same differences, slightly reduced results in the long-standing persistent, which is clear. But if you measure, it's not allowed because it's not powered. There were differences in between two groups. The follow-up was through 12 months, and the first visit was at 3 months, then at 6 months, and then at 12 months with a 48 Holter monitoring. But we also had in between ECG visits when atrial fibrillation occurred and the patient was symptomatic. And also these patients were failure in the study. So it is a follow-up through 12 months. As physicians, we have the responsibility to assess the risk-to-benefit ratio for each procedure we perform. And we are very lucky in this study. The benefit for the patient is very clear, because with a hybrid procedure in the CSAF study, patients benefit in 32% compared to the catheter arm. We compared the complication rate, and there were no significant differences in complications. The findings of the CSAF study are in line with the current literature. But till yesterday, because today is CES, we only had single center experience. There was just a hint that hybrid ablation can be beneficial. And now the CSAF study is the largest randomized prospective European trial, and it's a European trial with 9 different centers from 5 different European countries. When we started 10 years ago and designed the protocol, we never would have thought that we can get these excellent results and these huge difference. This is a randomized trial, and I'm sure, I hope, that these results will influence the next guideline committees. And I really hope that this study will bring EPs and cardiac surgeons together, because we know that challenging patients with advanced atrial fibrillation will benefit from these hybrid procedures. And we have learned, if we sum it up, together we are better.